After the image.
No, no. You'll see. I know. Okay. Thank you very much. It's now, oh, wait a minute, we're missing one trustee. Any minute. Well, do you suggest we wait for her, or? I'll say something off the record. Can I say that? Lovely, lovely Christmas decorations. Thank you, anybody who was, and everybody responsible for that. And please don't take this as a criticism. It's just a suggestion that we put up also something for the celebration of Hanukkah, which is a menorah, and the celebration of Kwanzaa, which is a Kinara, just so that we don't miss anyone in wishing them well this holiday season, which we all did. And I was going to save this for my big closing at the end, but we're waiting for one more trustee who's a bit tardy. So I'll say it now on behalf of the board, and your administration. We wish you all the best holiday season and a healthy, happy, and fiscally stable new year. And now she's overstayed the tardiness level. Where is she? Okay. Well, let's, we have a quorum, but we're not going to reach, we're not going to have any significant issues until she comes. So why don't we begin? Why don't I call the meeting to order? What time is it? I always get the time wrong. 4:09, which is the latest we've been. Okay. I'm Stuart Rabinowitz, and let me take the roll, starting on with Rory. Just
Rory Lansman. Jason Ebelow.
Lisa Newland.
Richard Becker.
Lisa Warren.
Dean Mahal.
okay. Amy Flores will be here shortly, but she's not at the moment. But nonetheless, since we have 6 of the 7 people here present, we have a quorum and we can begin the meeting. So she's going to miss the very exciting approval of the minutes of October 28th, 2025 meeting, which was in your materials, and this is addressed to board members. Do I hear a motion to approve the minutes of the October 28th, 2025 board meeting?
So moved.
You can speak slowly till Amy comes. Yes.
So moved.
Good. Is there a second? Oh, of course, Dean seconds every motion. Do I hear any discussion about those minutes? I think they're very accurate and precise. Well done. Kudos to Dan, who I think Eric did the minutes. Kudos to Eric, who did the minutes. All in favor of approving the minutes? Aye. All opposed? Abstention. I'm trying to stretch. Now, we have the second very exciting motion to approve the minutes of the November 18th special meeting of the Board of National Health Care Corporation. Do I have a motion to approve the minutes of that? I see.
All eyes on you, Director Flores.
Do not, try not to trip. It will be really embarrassing. Okay. Okay. Good evening. Dean, do you second the motion to approve those minutes? Yes. All in favor? Aye. Any opposed? Minutes approved and passed. We're about to present a report by our interim president and CEO, Richard Becker, followed by a presentation by our fantastic CFO, Chief Financial Officer, on the 2006 budget. But before I do so, I want to just say a couple of words about the leadership of the group. As you all know from reading someplace, Thomas Stokes will be our new Chief Executive Officer and President. He is currently finishing up a lot of work that he has to do in transition and closing his work at Cornell Weill, where he is Chief Financial Officer of Medicine, and Cornell University, where he is the Vice President of Finance. And he actually will not be able to begin until mid-January, and we don't know exactly what the date is. But thankfully, Dr. Becker has agreed to stay on and put off his ski trip. Is it a ski trip, I think? Put off his ski trip, making self-sacrifice as he has the whole time, so that we will not, until CEO Stokes is on board. So we will not have a time period, thankfully, whereby the bylaws, I would have to be the CEO if there's no CEO. But we've avoided that problem, not to go home and worry about that tonight. So, but I just do want to, in all seriousness, I mean, we're really excited about Tom Stokes. We think he's eminently qualified, and we can't wait to get started with him. But I just want to say a word about Dr. Becker. And I don't want it to, I can't control history, but I would not like his contribution to disappear when they talk about the history of this hospital. Because when we began, there was me and there was Dr. Becker. And 14 of the former executives left before we got here. There was no chief operating officer, there was no, house counsel. Of course, one person had 3 positions, so she took those with her. But there was no, I shouldn't joke about that, but there was no head of HR. There just was nobody at the highest level helping to run this institution. And Richard Becker came in, and through grit and hard work and commitment and prior contacts, managed to first hire a law firm which acted Manat, which did a great job, and most of their work actually involved running the place and taking the place of who were the C-suite executives. And Deloitte also was doing the financial end of things. And then Richard managed to hire a fabulous team of interim C-suite officers, all of whom are still here, thankfully, who have made us not miss a beat in terms of patient care. And that's really what it was all about. We did not want, I mean, there was a risk that it would, the gap at the top would filter down to patient care. But you didn't let that happen, and he didn't let that happen. And I think that whatever happens to this hospital, which is all going to be good things in the future, it owes a tremendous debt of gratitude to Dr. Becker's work over the past 6 months. So I just wanted to make that formally as the board's position and assessment of Dr. Becker. Is he blushing yet?
I am.
He is. Okay. And now let's put him to work. So you make your statement, and then we'll do the budget for 2026.
Thank you. Thank you. All right, is this working? Yes, good. All right, well, you did embarrass me, and you said you would, so you lived up to your, yeah. It's been a pleasure. It continues to be a pleasure. I'm not going anywhere yet, so I want to thank the board, first of all. It's been a pleasure, and it remains a pleasure to work with the board. The board, just so everyone knows, is an amazing board. I worked with a lot of boards I've never worked with a board as committed, and a board that faces as much of a steep climb as this board. And I think the conversations, both in public session and in executive session are forthright and analytic, and everyone should feel very comfortable that this board, really cares about NUMIC and New Health, and really is doing everything in its power, and I mean everything, to advance the mission and ensure the future of this organization. And so it's been a privilege to be part of that, and I thank you for that. I had, before I start, sometimes you get invited to say a few words, and I had the distinct pleasure and really an honor today. For those of you who may not know, today is World AIDS Day. It wasn't really on my calendar, but I got invited to say a few words because we had a big World AIDS Day conference here with really interesting speakers and some really neat information. And I just wanted to give a shout out to Dr. Yasmin, who is the director of HIV, our HIV program, and our associate chair, chief of infectious disease, and also Martine Michel Tour, who is the administrator and case management of HIV. And what was really interesting to me and struck me, because you're always kind of thinking, well, what are the kinds of things that we do here and do well here? And there are many. But today is World AIDS Day, and by the way, the world motto is called "Overcoming Disruption," which kind of made me laugh. I thought, well, it's very aligned with things, and so we're overcoming disruption. But what was presented today were the viral suppression rates for the country, which is around 65%, and higher numbers are better, right? The more you suppress HIV virus, the better it is. And that data is a little dated because the national rates haven't been updated since 2022. Okay. New York State, which generally does very well, the statewide rate for suppression is high 80s, maybe 90%. Okay. We take care of 540 patients or so in Nassau County. Our suppression rate is 97.5%. That's what I said. Unbelievable. And if you want to, and this is not simple stuff. People with HIV get resistant to the drugs. It's a constant, case management. They don't want to take care. They don't want to take these medications sometimes. It's a real, it's as much science as it is art, or as much art as it is science. And it's really a commitment. And we have an incredible team. And I just mentioned the two leaders, but we have an incredible team doing this. And boy, did I feel proud, as you should. This is something that's really amazing and important. And talk about aligned with our mission. Many of these folks, are vulnerable and economically, vulnerable, and they're people of color and diverse, and and Caucasian, and it's just a whole mix that really represents Nassau County. But people come here for two reasons, I think, for this program. One is because they may not have other choices, and we get a third of our referrals come from other places where they are managed as well, I think. But the other reason they come here is because we have a 97.5% suppression rate, and that's amazing work. So I just wanted to call that out because that's something that we should all feel proud of, and like I know I do, and it just represents the kind of work that's done throughout the hospital. It doesn't always get recognized, but this was just one bright moment that really kind of shined a nice light on things. So thank you for indulging me in that. I'm going to walk through a presentation and then say a few words, and then as our chairman said, I'll turn it over to Rich Miller, our CFO, to talk about the 2026 budget. I want to say a few kind of overview words. It remains a challenge. We're still working against the 2025 budget, which was really, in my view, an ill-conceived budget, not based on a lot of reality. And so we struggle against that. And And be forewarned, our numbers are not good relative to the budget. That doesn't mean progress has not been made and is not being made. Progress is being made in every area and in every corner of his hospital. Clinical, operational, financial, you name it, we're advancing. And we feel good about that. But there's a lag between what's reflected in our financial statements, what's reflected in in even some of our operating metrics and clinical metrics, and what is happening on the ground. And so we'll talk a little bit more about that, but I wanted to kind of go into that. We'll talk a little more too about the budget as we get there. So here's our current financial position. Again, the variance to budget. I think a more useful number too is to compare ourselves to 2024 actual, which is also a way to think about this. We have operating revenue that has different components in it. A lot of that is net patient services revenue, or in layman's terms, the money that we get from providing direct patient care, whether it's inpatient or outpatient or otherwise. We also have other revenues. Some of that, as an example, are monies that we may get from the state. We've received $25 million so far from the state and expect to get more, hope to get more this calendar year, as well as into next year. You can see that our operating revenues were $41.5 million unfavorable to budget, primarily due to lower than expected inpatient volume, about 8.5% lower than expected, ED volume, which is close to 5,000 visits year to date, lower than expected, around 11.5% lower than expected or budgeted. And A. Holly Patterson, slightly different metric in days, but days are about 5.5% lower. As long as I'm mentioning A. Holly Patterson, I want to acknowledge Joe Bendon, who's our new director. Good to see you, Joe. Kind of wave so everybody can see who you are. We just recruited Joe. We're thrilled to have Joe. I may have mentioned him at the last meeting, but I like to reintroduce people. So I didn't. Well, good. So here we go. And Joe's focused on A. Holly Patterson. So that accounts for a lot of our revenue variance versus the budget, and really versus actual. Again, the budget accounted for a lot of revenue that really was never going to happen. So that is a bit of a distraction in a way. On the operating expense side, we were $12.2 million unfavorable to budget, primarily due to higher than budgeted fringe benefit costs, a lot of which we don't have control over. Consulting expenses, which, as I mentioned, were around $8 million year to date, and that had to do with the abrupt departure of the C-suite that we reviewed before, and the need to bring in outside consultants to help manage and operate NUMIC. And then some utilities expenses that were unexpected, especially during the summer chillers, and more recently, although not reflected in this, is a boiler blow up. We'll talk about capital in a little bit, and that's very much on our capital list. We had a favorable to budget adjustment on the pension liability, and that helped us a little bit. But as you can see, we're obviously not happy with where the run rate is. We'll talk about the budget for 2026 and give you a context for that. I think we're still working on figuring out how to grow the volume, how to stabilize operations, and how to advance. Just to create a context, we've been at this as a full team for only about 3 months. Got here at the end of June, mid-June, end of June. Took a few months to get a team together, and then we advanced full speed ahead, and we've been making a lot of important changes. But it's not enough necessarily to reverse trends of decline that have happened that quickly. And so we're focused on that, and that's the work that lays ahead that, myself, this team are continuing, and then the new CEO who Stuart, described, who's very well equipped to do this, will continue with the team. So we're excited about that, but that's where we are for now. The operating budget, as I mentioned, one of the key priorities, we presented that to the Finance Committee on November 19th, and it was just approved at another Finance Committee meeting before this meeting. Rich will describe that in detail in his presentation. We have established a lot of trust and integrity with the VAP cash flow reporting process. And just so everyone understands what that is, that's the process that we utilize with DOH when we ask for supplemental funding. Again, we received $25 million year to date for that and are hoping to receive additional funding this year and obviously into next year, which will be needed to support us as we move forward and make changes and improve. We've implemented a routine reporting cycle, which is extremely detailed and again takes a lot of work and a lot of diligence. And we've had many calls with DOH where we walk through line by line and describe why is this number this way, what is this expense, what is this revenue line. So that's a very extensive process that Rich and the finance team, as well as I, have walked through, and we've established real trust, because unless you establish that trust and unless they see that there's integrity and that they can rely on the finance team here, they're not going to give you money that you need. And so we've established that, and in fact, we've asked them, is there anything else you need from us? And they've said no, and we feel very good about that. That's a very big accomplishment. All the IGT payments that we were supposed to receive have been received from New York State, so that's good and that's significant. We are in the process of renegotiating managed care agreements. We've got good traction on that. Our managed care team, led by Sam Shutman, is really working hard, and we expect some real progress there. We've resolved some disputed billing issues with different health plans. It doesn't seem like a lot. We've received $600,000 in payments so far. More to come on that. A lot of disputed claims, and that's a work in progress, and we expect more with that. Establishing our revenue integrity function. Laura Crable is leading that and is doing a tremendous job really revisiting and reworking how we bill and collect. And there's not enough time in the day to describe all the moving parts to that. We started a new initiative that's going to increase the integrity of that. And the greater the integrity, the more likely we will get reimbursed, and the more we collect for what we do in the short term or just in lay language. So that's really important and is happening well. Likewise, clinical documentation integrity. We've closed an RFP. We need, every hospital, by the way, can always improve their what we call CDI. And so this is an area where we know, especially here, that there's a lot of opportunity, and that will also result in capturing additional reimbursement over time. Perry El-Shanawani, our Chief Clinical Officer, has been doing a lot of great work. We've established a palliative and hospice care service. There are a lot of patients who are eligible for this. That makes a big economic impact. But not only does it make a big economic impact, it's just better for the families and the patients themselves. It's a better environment for the appropriate patients. And so we've established that. Patients don't have to leave the hospital. And that's really kind of a luxury for those patients. Our lab services successfully passed its DOH and most recently its CAP survey, which is an annual survey. Chris Amoroso, Christine, is our new Chief Quality Officer, is leading our preparations for a Joint Commission triennial survey. You may remember that I said the window was going to open for a resurvey 18 months after our last, which would have been this month. Joint Commission extended that for another year, essentially. And so that window doesn't open until January of 27, which is wonderful news for us. It gives us the time we need to prepare appropriately, and Christine is attacking that as well. Clinical decision service or observation beds. Very often, if you have a patient who only needs observation and is admitted, and you bill for that patient will get denied, and you end up losing money on that patient. So it's important to identify which patients qualify for an observation status or a CDS status and assign them to that appropriate bed. We were not doing that well until Dr. El-Shanawani her team intervened and has helped with that. And so we're really increased the number of CDS admissions, and that's really helping us with denials. In addition, I've talked a lot about how we've decreased the length of stay, and just care in general is improving. We're seeing that in a lot of little ways. A good amount of that is what Dr. El Shanawani and Rivka Mintz, our chief nursing officer, are doing together to create interdisciplinary rounds with the interaction between physicians and nurses. And the more physicians and nurses talk to each other about the plan, and the fact that that happens several times a day is a good thing. It keeps us very abreast of what's happening with each patient and make sure that we are discharging patients as soon as they can be discharged, which of course benefits patients throughout the hospital. Again, I'm very proud of the work that's happening, decreasing length of stay. You can see a decrease in med-surg length of stay by 1.7 days is enormous. And so we're continuing to go in that direction. You know, we're not going to let up until it hits 4, right? So we're very focused on that. I'm not sure why our delinquency rate for medical charts increased, you know, I guess soon after I got here. Maybe it was just my arrival present, but it happened. And so now we're back down, you know, closer to where we should be, not quite, but we're very focused on that. I want to thank, you know, our chairs and our clinical leadership, our physician leadership for that. It's taken a lot of work, a lot of focus to make sure, as well as our resident physicians who are very involved in making sure that documentation happens and these, you know, charts are closed. So that's really great. We also, and this is a great story at the bottom, where we had a number of patients who really didn't need to be in the hospital, but for a lot of different reasons, many of them social reasons, they were just lingering here in the hospital. And you can see from October to November, from September to October to November, I mean, really the blue line tells the story the best. 35, 35, 7 at the end of November. And that's going to even drop. I think it's dropped further. That was November 1st. So that's great because we're generally not getting paid much to take care of those patients. Perry just told me we're getting 0. So that's not much actually. So, and so reducing that number to 0 is the target, and we're getting close. So that's terrific. Nursing, you know, just to, you know, show you again, the trends continue. We're saving $500,000 a month. $500,000 a month in agency and overtime management. Rivka Mintz, our chief nursing officer, has been incredible about this, but it's not as if, you know, you just wave your hands and, you know, or sprinkle some dust and it happens. It's a lot of work. It's huddling with folks twice a day. It's being present. It's being visible. It's engaging our own staff. And it's helping them feel passionate about what they do and ensuring that what they do really matters. And then it's also just making sure that we're staffing appropriately. And so I think Rivka and her directors are doing a tremendous job, and it shows up in huge savings. And so we're going to continue. There's more work to do. As I talk about operational strategy, you know, Trent Crable, our chief operating officer, and I have been working, and the whole team sat today and had about a 1-hour session on how we can focus on, you know, unnecessary overtime, and manage payroll a little better. We want to make sure that when people work overtime, that it's appropriate and that they get paid for the overtime that they're doing. But we also want to make sure that we are using overtime appropriately. And we think there's some opportunity there to improve that on the frontline operations and doing a lot of what Rivka's done in nursing, but applying it across the board. I've talked a lot about the dashboards that the Deloitte team had developed for us. It's been a lot of work. And I feel like I keep saying this, but it's really true now, that, you know, these dashboards are almost ready to, I think we have a call this week or next, to make them active and be real tools to management. They're still not ideal because the data is only populated, you know, on a weekly basis. Whereas if we had, you know, some better systems, that kind of data
can get populated on a daily basis and be very useful in the type of management that we're talking about. But we're not quite there yet. But we're, this will be a tool that will be very helpful. I mentioned staffing, and Trent is leading the way to really address some of our staffing issues, making sure that we're staffed appropriately throughout the hospital. And that's both clinical and non-clinical positions. We're looking at all of that and just monitoring it and making sure that we're laser focused on, how we spend that money. We're reviewing and restructuring some departments. We're talking carefully about that. We want to make sure that, folks are managing at the skill levels that they have and that they have the right scope of responsibility. We're still looking at that and digging into that, and more to come. But I think, we'll get to a place that will make us even more efficient. I'll talk about capital budget in a second. I have another slide on that, so let me skip that point. But we're in a very good place with our capital, and we have a bunch of focus projects, that I've mentioned before: ambulatory care transformation, the perioperative process, supply chain infection control, and some others that are continuing and we're getting good results from. With capital, we had submitted a detailed capital needs plan for $50 million to New York State DOH as part of a request to accelerate the monies that have been awarded by the state legislature, but that were spread over 5 years, from 2026 through 2025 through 2030, state fiscal year 26 through 30. Senator Sheila Bino has been very helpful in pushing to get that accelerated so we can access that money sooner. And I'm pleased to say that our understanding is DOH has signed off on that, and now it goes to DASNY through a bonding process, which can be time consuming, but we'll get there. But the good news is I believe that we're going to have access to that money sooner than later, which will help address a lot of really important needs. That was really heavily weighted towards infrastructure, Tom, so you'll smile for that. As our aging systems continue to represent a lot of challenges, I will compliment, Tom's teams. They really, we had a big boiler blow up recently, and they were here, much of the night, weekends, just making sure that, the boilers, were working and that we could get temporary boilers. And it was a real fiasco, but the team under your leadership did an amazing job. So thank you for that. The state has inquired. I got a call the other week about, what kind of funding we would need to advance and improve our electronic health record, whether we stay with the same vendor or not. It's a big number. We talked about it. We'll have to nail it down. But the reason I mention it is that, it was a very nice call to get spontaneously, that the state is interested in, and thinking about, what we're going to need for both revenue cycle upgrades and electronic health system upgrades. So we'll, again, await next steps on the capital budget from DOH and others, but, a lot of positive things happening. Dan Lindenberg is leading our legal department. We've, been trying to keep Dan busy. It's hard sometimes to find things for him to do, but I'm just joking. He's done an amazing job and working very hard. These are some of the general areas that he's focused on. We've got a great relationship with NYFA, and we've really, got real clarity on their process, and I believe that they've got a lot of trust in how we are conducting ourselves and that we're following the rules. And if there's a miss, we are very open and very responsive to them as they have been to us, and so that's really been terrific. We've got a lot of different agreement templates that we're building so that we can have standard types of contracts where that makes sense. Dan's working on that. Dan and Tom Byers have helped optimize our RFP process. That is not a simple process. Doug Brown spent way too many hours on that, but we've transferred that and we're managing that well, and we've been able to get RFPs out and turned around reasonably quickly, which is terrific. We're looking to expand, Dan's support. I like talking just to you, Dan, but, I guess we need to, expand that. We have a chief compliance officer starting. I think that person starts in mid-December, which is great. We want to make sure that's a critical position. That person will report to the board, but be supported by Dan and the CEO. So that's a very critical position that we'll focus on. We've got a lot of contract modernization that's happening, updating major vendor agreements. We've got a number of pretty significant negotiations that are happening with clinical and non-clinical vendors, and we'll continue to remain focused on that. I showed you this slide last time. I don't want to focus too long on it. This is Tara Brown's area. We're very concerned about workplace violence, and so I asked Tara to come up with a plan, which she did, a 90-day initiative that has started with a letter from me and is very focused on a number of very clear objectives to really build trust, make people feel safe, ensure that they understand what to do when they do feel threatened or when they witness, a potential threat. And there's a lot of different amounts of education and engagement that go into this over this 90-day period, and then there's reinforcement of that as we go on. So I just raise this for everyone to know that we recognize this as an issue, and it's something that we are quite keenly focused on. So that's really my summary. We are continuing to focus. I told you guys you'd see this slide, over and over again, and I really mean it, though. I think the goal here clinically is to align with our clinical teams and our staff to really improve clinical, operational, and financial stability. And, even though it's not completely reflected at a high level when you look at the numbers, I can tell you that on the ground, it's happening. And you'll see some of that as Rich Miller presents the budget. You'll see areas where we're making remarkable improvements and, that are very impactful. We're rebuilding and educating teams around best practices, and you can see it and you can feel it. And kudos to the staff for embracing the amount of disruption and change that we've been introducing. And I really mean it. I mean, people are very welcoming for the most part of the type of change that we're introducing. Sometimes there's a little resistance, but more often than not, in fact, almost all the time, people are okay. Let's do this differently, and we'll see a different outcome, and we do. And then we're going to begin with the board a much longer strategic planning process for the transformation of NUMIC that will really ensure the future. I'm looking forward to, remaining engaged with that, to the board's liking, and excited about that. So that's really my presentation. I want to, turn it over to Rich Miller to present the budget. But before I do, I first want to thank Rich and his team, Samantha, Rich Bernash, if Rich is here, and the whole team. I'm sure I'll leave people out, but really, you can't appreciate the effort that has gone into this. When you form a budget, typically you build a budget based on a previous budget that has integrity and was built on a foundation of real data and real variables that we know and trust as an executive team. That was not the case. And some of that, I would even say just the last administration was not to blame. There's just not those systems here for many, many years that would support that kind of process. And so we did the best with what we had, which was imperfect data. And Rich can talk a little more about that. But the amount of labor and thought that went into this, and I would also, applaud our department managers and our clinical leadership, because we sat with each department, for hours upon end. And I know it probably seemed much longer to them than it did to us. But that said, we were very impressed with how prepared people were, the data that they presented. It's a learning process. We become more educated as we listen to our clinical leadership and their support teams. It's really a process, and then we take that and we make sausage out of it, and that sausage is the budget. And that process was, a very high integrity and well-conducted process, despite not having all the tools that you might want to have. And so for that, thank you, Rich and team. Phenomenal job. I will say, too, that, as you'll see in the budget, we're going to, it's not a surprise, or maybe it is a surprise, but we're going to project a loss, a significant loss. We're hoping for additional state support to mitigate that loss. That will be very important, certainly over this next calendar year or the rest of this state fiscal year and state fiscal year 27. We'll expect and need a substantial amount of state support to advance and support the period of time that it will take to transform NUMIC into an organization that's sustainable. But with that, let me not steal any more of Rich's thunder, but turn it over to you for the presentation. Thank you, guys. Let's see. This one? Bingo.
Thank you, Dr. Becker. And I'd like to echo Dr. Becker's comments, acknowledging the efforts of the finance team and the leadership team led by Dr. Becker in pulling the budget together. And one piece of all the work the department heads did this year, I'd like to point out, which has not been done in over a decade at the organization, is to have those meetings. Certainly all the large departments and many of the smaller departments came together and met and reviewed the needs, and it was a collaborative process to pull the budget together. So thank you to all the department heads. This is a collaborative team effort to pull the budget together. So as a safety net provider and serving as one of 3 level 1 trauma centers in the county, Nassau Healthcare Corporation has experienced operating losses for many years. The drivers of the losses include a predominantly high Medicaid and Medicare payer mix, large behavioral health and substance abuse program, and high costs incurred due to competition for talent with other healthcare providers in the downstate New York market. Nassau University Medical Center also experiences high levels of uninsured patients, particularly in our ambulatory services like the emergency department and our ambulatory clinics. Through October of 2025 year to date, as Dr. Becker just reported, we have seen declines in patient service volume. 8% lower on inpatient discharges as compared to 2024, and about 11% lower on emergency department visits, again, compared to last year. Other ambulatory visits, such as the clinic, are tracking in line with last year. NHCC will incur approximately $8 million this year in consulting and outside service fees due to the abrupt leadership turnover that was described earlier and ongoing litigation. Management is projecting the 2025 operating loss after other post-employment benefits, that's retiree health insurance, at a loss of $137.9 million, and that's inclusive of $43 million in federal and state aid that we've received in 2025. The 2026 operating budget reflects an operating loss of $167.1 million after OPEB, which is an increase in the loss of $29.2 million as compared to the projected 2025 results. The increase in the loss is due primarily to certain non-recurring items totaling $42.5 million. Before the impact of these non-recurring items, the budgeted operating loss after OPEB is $124.5 million, or an improvement of $13.4 million as compared to the 2025 projected operating results. And we'll talk some more about that as we go forward. It's important to emphasize the conservative approach taken in composing this budget, as well as the lack of performance and statistical data Dr. Becker just alluded to that would typically allow management to build the budget with more operational insight and precision. Lacking such data and supporting analytics, the budget we present is built with the best information available, albeit highly imperfect. We do expect current management efforts to result in continued favorable improvements in both revenue capture and expense management as we progress through 2026. The current board and management team are focused on improving operating performance and patient access to quality care while engaging with New York State to access the aid necessary to ensure NHCC's sustainability. The board is also leading the development of a state-mandated transformation plan with a report due about a year from now in December of 2026 that will guide the future vision for NHCC. All right, now I'm going to try to make this a little bit larger. Better? Okay. All right. A little before the bottom, you see the shaded blue line has the operating loss after OPEB. Lower right-hand corner, you can see that at 167.1 million. I'm going to walk through the major assumptions that are in the budget for each of the lines that you see here. And I'm going to start up top with the operating revenues, which you can see are at $586.5 million. That represents about a 9.6 million decline, or a 1.6% decline versus the 2025 projections. I will focus on first on the largest number on the page, which is the net patient service revenue. And in 2026, we're budgeting $461.4 million, which represents an increase of $27.1 million, or 6.2% over projected 2025 results. This is due primarily to management initiatives to mitigate the continuation of current year declines in emergency visit volume that was discussed previously, combined with payment rate increases, which we'll detail in a moment, and revenue cycle improvements. The operating budget anticipates that patient service volume will be flat in 2026 to the 2025 projections. The budget reflects the published rate increases for Medicare, Medicaid, workers' comp is applicable for inpatient, ambulatory, and physician services, and for commercial payers where contracted rates were in place, those are also included. There are management initiatives related to revenue cycle management, principally in the areas of revenue integrity, such as charge capture, as well as managed care contract renegotiations. Both of these initiatives are well underway and are expected to yield $20.8 million of additional revenue in 2026. For A. Holly Patterson Nursing Home, the patient service volume is projected to be flat to 2025, and payment rates from Medicaid, which is the principal payer at A. Holly Patterson, are expected to decline by 1% in 2026. On the other operating revenue lines, we have multiple components. First, the intergovernmental transfer. Sometimes you've heard that referred to as the DISH payments or the UPL payments, are budgeted at $47.5 million in 2026. Slight increase of about $1.5 million over 2025. This amount includes $37 million in DISH hospital payments for NUMIC, $9 million in upper payment limit payments for A. Holly Patterson, and $1.5 million for physician upper payment limit services. The contracted services provided to Nassau County, as well as the Correction Center, are budgeted at $22.3 and $19.7 million respectively. These amounts are assumed to be relatively flat to the 2025 projection. Federal and state aid is budgeted at $8.5 million for 2026. This consists of $6.4 million of FEMA grants related to expenses NUMIC incurred relative to the COVID-19 pandemic, and $2.1 million of New York State grants. If you look just to the left of the $8.5 million, you'll see in 2025 we received will receive by the end of the year, $43 million in federal and state aid. That amount includes $15 million of FEMA grants, so we had about $9 million more in FEMA grants in 2025 than we will receive in 2026. In 2025, we did receive $25 million related to the New York State VAPAP program. As of going to print for the budget, we do not yet have clear definition on the amount and timing of the VAPAP funding for 2026, so we were not able to include any in this particular budget, but there are ongoing discussions with New York State officials regarding this, and we are expecting there will be payments again. We just don't have definition at this time to include that into the budget. On miscellaneous revenue, we're budgeting $27.1 million. That's a decline of $3.9 million from projected 2025, and that's due to updates that we received post-development of the 2025 projections. And then on operating expenses, I'll start with salaries, the largest line within the operating expenses. The salaries are budgeted at $312 million. This reflects an increase of $4.3 million or 1.4% over 2025. The increase is due to contracted step increases for union employees and a small amount of staff additions in certain clinical specialties to improve access to care, and certain administrative functions to reduce the use of outside services that are partially offset by reduction in outside services or agency costs. The current management team is focused on filling vacant positions in order to reduce the use of overtime and outside agency use, which are both paid at premium levels. Fringe benefit costs, you can see on the next line here, are budgeted at $196.1 million. This is an increase of $12.4 million or 6.7% over 2025. The increase is due primarily to an assumed 8% increase in the health insurance costs for both active and retired employees, as well as a 12.5% increase in pension expense. The fringe benefit costs as a percentage of salary cost, after adjusting for what we charge back through the Nassau County billings to the county, is at a percentage of salary at 58.9%. So almost 59% of every salary dollar reflects in fringe benefit costs, again, primarily health insurance and pension. Management will be initiating a review of the fringe benefit costs to benchmark NHCC versus peer organizations to identify potential areas for cost efficiencies. On supply expenses, you can see we're at $55.4 million. That reflects an increase of $1.6 million or 3% over 2025. The increase is due to inflationary trends in both medical costs, medical supply costs, and pharmaceutical costs. Other expenses are budgeted at $115 million, reflecting a decrease of $9.7 million or a reduction of 7.9% versus 2025. The decrease is primarily due to reductions in outside services such as consulting costs and outside agency costs. On utility costs, we're at budgeted at $21.1 million. That's an increase of $900,000 or 4.2% over 2025. Again, the increase is primarily due to assumed inflation trends. And then finally, on depreciation, we're budgeted at $23.9 million, which is roughly in line with what we're projecting for 2025. Okay, and looking at employee benefits for the New York State Pension and OPEB, we've budgeted at $30 million for 2026. This is equal to the 2025 budget and consistent with the prior practice. The actual 2025 amount for OPEB will not be known until we receive actuarial reports in March of next year, and any required adjustment will be reflected in the 2025 audited financial statements. The New York State actuarial pension adjustment, which Dr. Becker noted earlier, was a positive $8 million for 2025, has been budgeted at $0, consistent with the prior practice. Some years result in a charge, a negative amount, and some years in a positive amount. So traditionally, the organization has budgeted at $0 for this, and we're being consistent with the prior practice. So net of the two items, it's a $30 million charge for OPEB, which brings us to the operating loss of $167.1 million. On non-operating activities, below the operating indicator, you can see there's interest income, interest expense, and a deferred loss on debt refunding. The net of these items is a loss of $1 million. And finally, on capital contributions, we've included $18 million. $6 million of that is from the New York State Capital Transformation grants that have been previously awarded, and the final drawdowns will happen in 2026. And the remaining $12 million, to bring it up to 18, is the $50 million New York State capital grant that was awarded in the New York State budget for this fiscal year. And this represents the first 2 years of that 5-year grant. We're trying to accelerate that amount so that it could be more, and we could accelerate those capital additions, but what we've reflected here is what is baked into the New York State budget for this current fiscal year as well as next fiscal year, and that's 12 million, again, plus the 6 million on the prior awarded grants brings us to 18 million in capital contributions. So after these non-operating activities, the 2026 budgeted change in net position is a loss of $150.1 million. There we go. Okay. Thank you, Sam. So a picture can be worth 1,000 words. So put together a operating loss bridge here to highlight the significant items that are taking us from our $137.9 million loss in 2025 to the 167.1 loss after OPEB for 2026. So first is the salary and fringe benefit costs that I outlined. That's about $16.7 million. The lion's share of that is the fringe benefit costs. About 12 million of the 16 is fringe benefits, and a little over 4 million are salary costs. Other expenses net, so these are things like the supply inflation, utility inflation, is $5.2 million net. Then helping to mitigate these increases in the loss is $6.8 million on those government and contracted rate increases I described earlier. Again, that's Medicare, Medicaid, workers' comp, and certain commercial payers that are already contracted. Helps to mitigate the loss by $6.8 million. Then we have a reduction in other expenses. That's the consulting and agency fees that are improving by $7.7 million in 2026. And then we have the revenue cycle and managed care contracting initiatives, which improved the loss by $20.8 million in 2026. And again, those initiatives are both well underway. So taking the sum of these 5 items and adding it to the projected loss for 2025 gives us a subtotal of $124.5 million, or a $13.4 million improvement versus the projected 2025 results. Unfortunately, we have the non-recurring items I mentioned earlier. The fact we don't have enough information yet to budget on the VAPAP funding from the state, that we have a lower FEMA reimbursement next year as the COVID-19 reimbursements have run its course, and we're not budgeting to have a positive adjustment on the pension expense. That was $8 million. So the sum of those items is $42.5 million, and that brings us to the loss that's budgeted of $167.1 million for 2026. The new interim management team, fully in place for approximately 3 months, has initiated significant changes to improve clinical, operational, and financial management at NHCC, with substantive positive changes already demonstrated in various revenue and expense metrics throughout the organization. Dr. Becker touched on many of those in his report. Despite these immediate successes, there are still automatic and contractual increases in expenses that are challenging to offset in this relatively short period of time, ultimately making the 2026 budget, without additional external financial support, worse financially than the 2025 year-end projection. We do expect current management efforts to result in continued favorable improvements to both revenue capture and expense management as we progress through 2026. That concludes my comments.
Do I need to read the whereases? No. Good. I move that the NHCC Board approve the fiscal year 2026 budget.
Second.
Any
I have-
discussion? Any
Sorry.
questions from, I know there's going to be time for, after this, there's going to be more time for questions or comments from members of the audience. And I'm very excited because actually for the first time, one person pre-registered for their comments. But in light of the budget that just went through, if people have any questions pertaining to the 2026 budget and its relationship to 2025 results, we or Rory Lanceman or anybody else who has any comments or questions can now pose them if they wish.
So, yeah.
You.
Me. Yeah, so as Stuart said, I chair the Finance Committee. And let me start by saying, Rich and your whole team, thank you so much for all the hard work that you put into it. I've had the opportunity to see it up close, to be on Zooms with you and calls with you and meetings with you. And it gives me a lot of confidence that what you're producing and what we're looking at is real. And that's the first thing you want out of a budget, that the numbers, the projections, the estimates are rooted in reality. And the reality is that this management team has made extraordinary progress, and this budget reflects that. I just want to very quickly highlight what Rich laid out here in this chart in particular. Can you bring up the chart with the red and the green? While he does that, I'll start by saying that
There it is.
for 2025, the hospital lost $137 million. That $137 million would have been $162 million had we not gotten the $25 million in state aid from the governor shortly after this board took over. The two columns, the columns next to those, where the budget goes down or the loss increases first by $16 million and then $5 million, those are things that are out of the board's control and out of management's control for the most part. They include salaries and fringe benefits. And once you start going up the green bar ladder, including most particularly the $20.1 million, the last green bar there, that is almost pure management operational improvements at the hospital. And so when you get to that next red bar, which is $124 million, that is a $13 million improvement in the hospital's budget situation from where we end 2025. And then the reason the next bar is not green or red, even though it goes down, is because at the moment it's unknown what state support we're going to get from the governor and the legislature. But I know that the governor and the Assembly and the Senate are committed to this hospital. So that number is going to be a number that is meaningful. I'm sure of it. So at the end of the day, what has happened here in a few short months with Dr. Becker's leadership and the leadership of everyone in this room, whether you're close to on the 19th floor or somewhere else, is really reflected in this budget and in the beginning of the staunching of the bleeding of the finances of this hospital. And I just want to thank again the management team, the finance team, and everybody who has contributed to making what is really meaningful progress in securing the financial stability of this institution. Thank you.
I want to say I completely agree with every word Rory said, and that's the first time that has ever happened. But I do agree with everything you said about everyone. So are there any other comments by board members or, yes, Dr. Lisa Newell.
Just very quickly, data always tells a story, and we have to be very conscious of the type of stories that we tell based on the information that's presented. And while it's a lot of financial information to take in, I hope everyone is recognizing that there's a solid story here about the hard work of this staff, the hard work of the leadership under transition, the hard work as we manage this institution, but also a deep commitment to the mission and purpose of this hospital and even A. Holly Patterson and the work we do in the correction facility. But that is part of the mission, and there's such deep alignment that the board as well as others see from the staff. And so this story is attributable to a lot of the work of you in this room, your colleagues in this building, and in other locations affiliated with this corporation. So kudos to us.
I also agree with every word you said. Any other comments by board members or in the audience? Are we ready for a vote on approving the 2026 budget as recommended by the Finance Committee? Yeah. All in favor? Aye. Opposed? Abstentions? It's unanimously passed. Thank you. Great job. Excellent job. Okay, now it's time for public comment before we go into executive session. And we have to start with the person who registered. They probably went home by now, right? So I'm very excited to hear from the person who registered. But I'm also happy to hear, as you know from past practice, anybody who wants to speak, we give them a microphone. We ask that you keep your comments or questions to a few minutes and that you address them to me, since I'm used to taking slings and arrows, but that we try not to argue with each other, but rather just seek information. There'll be plenty of time over different settings for us to argue with each other until we reach conclusions. Okay, so who is the first and only registered speaker? There you are. We're going to give you a microphone.
Thank you. Hi. We had a great volunteer program, and in May, it ended. We get calls in HR all the time. In fact, right before this board meeting, I got a call from a parent. We're going to open up the volunteer program again?
Yes, why not? Of course.
Tomorrow.
As soon as Dr. Becker implements it, which will be soon.
Yeah, we'll no, in all seriousness, thank you. Lots of things going on, but we would love to open up the volunteer program. In fact, we started a program with Hofstra where we had some students come over and volunteer in advance of their semester working in our population health area. That was just kind of a one-off, but we would love to kind of grow the program, revisit what it was, and build on it. So absolutely, we will. I will send some emails about it, which is what I do very well, tomorrow, and we'll start exploring that. And if you want to email me, rbecker@newmic.edu, please do, and we can have you involved in whatever. Or at least you can volunteer.
Yeah. I would like the record to reflect that the students who were here interning from Hofstra are students of the Stuart and Nancy Rabinowitz Honors College at Hofstra University. So let's be clear about that. Any questions or comments? Yes, sir.
So on behalf of management, I want to thank this group because it's real. We look forward to doing this with you and the support that you gave us when we were sitting there talking about it. You challenged us, Richard. You challenged us. Trent challenged us to do what we had to do. We did it with you guys, and I want to say thank you.
Thank you. Thank you. I can tell you that, well, we may make decisions that people disagree with, or maybe even make a mistake sometimes. One thing we will always be is fully transparent and honest with you. And you will hear the good news and the bad news. And that's a commitment from every single member of the board, not just me, and from management. So, if we, well, let's see. I mean, if we wanted to, we could have made an estimate of state aid for this year, which would have put us significantly below the deficit of a year ago. But we don't do things like that because that would be a guess on our part. And we don't want to do that. We want to be conservative and give you the real story about what may happen in the future and what has happened in the past. Any other questions or comments? Yes. Yes. The reason it was planned for is we use comparables, and the budget, which is not his compensation, which is public matter, I mean, is not 1.7, it's 1 million plus the possibility of an incentive if certain metrics are met at the end of the year, up to a maximum of 250,000. That money is less than the CEO makes of Erie County safety net, and much less. I don't know what Westchester Medical Center is doing, but I want that job because that guy makes in multi-million dollars. And why do they make? And by the way, the new CEO is taking a big salary cut from what, of course, while Cornell is not us, we know that, but he's taking a salary cut despite the fact he has a family to support. He has kids in college, God forbid. So, and you get what you pay for. There are areas where we can make savings, but we're looking for a CEO who will continue on Dr. Becker's path to make this a sustainable, financially sustainable hospital that doesn't have to go begging to the state or the federal government every year for hundreds, $100 to $200 million deficits, and yet still is completely committed to our mission, which is to be the safety net hospital for the most needy people in Nassau County. And it takes a skill set and experience, and the place to save money is not there. The place to save money are in less significant positions. We thought long and hard about it, and we weren't happy with that. I mean, we would have been much happier if, we could have gotten somebody for a couple of $100,000. That ain't going to happen. And so that's why we did it. We did that. The raises, I mean, there are step increases that are according to the union contract, and, we have to talk about that. We have a union contract. We know that that lapsed in 2022, I believe, and, we have to address that in time. Meanwhile, and we will. At the present time, we're just struggling to keep our head above water, given what has happened in the past and given what happened during the transition, where, by the way, it was not only 14 senior people resigned, but computers were wiped and files were shredded, and there was a whole lot of chaos. And we've been busy making some kind of order out of all of that chaos. I'll tell you, I shouldn't say this, well, I'll say it anyway, you know that. We've got to, at some point, we have to take a look at the benefits. We have to take a look at salaries and benefits. And, we actually owe, or are accrued liability for health care for our employees is $9.7 million a month, per month, for our health care, for current employees and retirees. We have not, for years and years, been funding that from our cash because we don't have it. And so we have been, in a sense, the state has been funding that. NYSHIP has been funding $7 million a year out of a month. $7 million a month out of our $9 million. We've only been funding $2 million a month for that. And so isn't that wonderful? Well, the state is not happy about that because we owe them hundreds of millions of dollars for paying our direct, benefits for our employees. And our balance sheet reflects it by showing $1.5 billion, $1.5 billion of a deficit, much of which is attributable to our not paying the full amount of health care per employee. Try to go to a wealthier hospital or institution and say, hey, become our partner, which we're going to try to do in many ways, because we think connecting with other hospitals will be in our long-term interest. Show them a balance sheet where, yeah, sure, I'll take half of the $1.5 billion deficit. That is going to be very hard to do, I would say, because partners are not dumb. That's why they have more money than we do. So, so that has to be addressed. There are numerous issues that have to be addressed to make us sustainable, but not yet. And this budget, does not have any layoffs in it. This budget does not reduce the staff. This budget continues to the 2026 budget. And in fact, it at least lists as a liability the full $9 million per month, that $9.7 million per month for health care. As opposed, now, whether we could afford to pay it is a different issue, but at least we're taking that into account in the deficit that you see, which is substantial. Anyway, that's my answer to that. Anyway, any other comments? It was a great question. I just didn't feel like, it wasn't the most easy thing. So, any other questions or comments? Or yes. No, not you. Somebody before you. Then you. Yes, you raised your hand.
Yes.
Yeah. I can't hear.
Any department closings?
There are no department closings in this budget. Yes, back to the volunteer. You can't make changes to the health insurance without collective bargaining. So no, there are not going to be any changes to health insurance without bargaining, collective bargaining with the unions. The unions are partners in this, and we have no desire to reduce their input or influence. Anything else? Can we go to executive session where we can grab a snack? Okay. Do I hear a motion for us to go to exec? Oh, God. Okay. Would you read it, Dan? You're the lawyer. What? I have to read it? Okay. I do appreciate the speakers, and I do appreciate those who are in attendance. I will now entertain a motion of the directors to conduct an executive session pursuant to Public Officers Law, Section 105, and Public Authority Law, Section 3402, 10B, for the purpose of considering matters regarding medical, financial, credit, or employment history of a particular person or corporation, or matters leading to the appointment, employment, promotion, demotion, discipline, suspension, dismissal, or removal of a particular person or corporation, and, underlined, for the purpose of considering strategic marketing plans, analyses, evaluations, and pricing strategies of the corporation relating to business development, which, if disclosed, would likely injure the competitive position of the corporation. And if I didn't read that, I'm sure we'd have 9 lawsuits filed against us for violating the Open Meetings Law. So given that, is there a motion to go into executive session for these purposes? Motion by Jason, second by Lisa. All those in favor? Aye. Against? None. Abstentions? None. So we will go into executive session, and for the hardy people who want to stay, we'll be back having snacked, and having gone into executive session. Thank you.
At its September meeting, the NHCC directors amended the bylaws of the corporation to conform to legislative changes made to Public Authorities Law, Section 3402. The attached proposed amendment is a technical correction to implement a change that was inadvertently omitted from the prior amendments. This change implements the legislative direction pursuant to Section 34022A of said law that the chairperson of the board be appointed by the governor. This proposed amendment is being put forth for the director's information and consideration only. Pursuant to Article 9 of the bylaws, any motion to amend the bylaws shall not be adopted until the next succeeding regular meeting of the board. If acceptable, this amendment will be adopted at the next meeting of the board.
Is this a motion you want approved twice?
It's in twice for revision of the bylaws?
No. You're just notifying us, right? You don't want to vote on this.
No, I know that, but I can talk really loud.
Okay.
I'm just noting.
Procurement then, Dan?
Thank you. Well, that just all went on video. Okay. All right. Yeah, so that was just for notifying. All right, so the legal procurement. The Legal and Audit Committee unanimously recommended the board approve the amending of the Tier 1 and Tier 2 legal rate structures and billing guidelines. These schedules and billing guidelines, which are referenced in the corporation's procurement policy LD 001, have been in effect and unchanged since 2007. The amendments more closely reflect current market conditions and will ensure NHCC's continued ability to retain qualified legal counsel, support effective and efficient legal service delivery, and support NHCC's operations and mission. This is here on recommendation of the Legal and Audit Committee for approval.
Is there a motion?
I would ask for a motion.
Second? Discussion of this, it was gone over in great detail, and really good changes have been suggested based on the market by Dan, and we appreciate the hard work that went into that. And we think the result is going to be good representation at no higher prices, maybe lower.
And this is this is Resolution 243-2025.
Any further comments or discussions? All in favor? Aye. Opposed? Abstentions? Unanimously adopted. I'll read this. The Legal and Audit, but stay there because I think you're still coming up for something. The Legal and Audit Committee approved the retention of Grant Thornton as to perform our calendar year 2025 audit. Grant Thornton has been our audit firm for a number of years. They start off with an advantage of knowing us, including the ugly part and the regular parts. And they did a good job that was accepted on the last audit. Probably next year or the year after, we'll probably go out for an RFP on new auditors, but this wasn't the time, and therefore the committee the Legal and Audit Committee approved their retention for the 2025 audit. I don't think actually a motion by the committee needs, I don't think a committee resolution needs a motion, but who am I? So is there a motion to approve that, Grant Thornton, for the 2025 and accepting the committee's recommendation? Yes. You can't vote.
I'm just saying, yes, you need to do a motion.
Second? Oh, Rory said yes, sorry. Second? Second. All right, all in favor? Aye. Opposed? No. Unanimous.
No, that was Resolution 243.
Okay, now the approval of contracts. Dan?
What's the range? Your board packet includes a list of contracts entered into by NHCC that do not require board approval, but is providing notice to the board of the contracts entered into. Your board packet also includes a list of contracts entered into by NHCC that require board approval and have received approvals by the CEO and President and the Legal and Audit Committee. This is for resolutions 246 through 274.
Which are included in the materials and which are included in public posting then?
That is correct.
Is there a motion to approve? Motion to approve. Second, Dean, any discussion on those contracts? Okay, all in favor? Opposed? Unanimously adopted that resolution. Eric? And as we're about to do the credentials, but before we do the credentials, there's a correction or an amendment to what has previously been made public, and I call upon Dr. Newland to make that amendment.
Okay, as chair of the Medical and Professional Affairs Committee, there's just a correction needed on the last page of the materials in our packet, calling for follow-up business, which is item Roman numeral 7. The status for Dr. Paul Weinberg should be recommended the status as pending. So right now we need to have a change from active attending recommendation to pending status recommendation.
And that was a correction to the published material, but that is a result of the board vote as well, right?
Correct. The committee vote was for that status.
Right. Any discussion of the recommendation of the Credential Committee as corrected by Dr. Newland? No? All those in favor? Aye. Opposed? Nay. Call the motion. Is there a motion? Yes. Amy made a motion. Lisa Warren seconded it. All in favor? Aye. Opposed? All right. I'm happy to do this one. Is there any further business? Perry, you have any? No? You're all right? You're okay? All right. Shakira, you got any more? Okay. There's no further business. Therefore, I ask if there's a motion to adjourn the meeting. Second? Yeah. All in favor? Listen, to those of you who are here, my wife says it's sleeting outside and dangerous driving, so be careful on your drive home.